The kind introduction. First of all, I would like to thank the organizers for inviting me to this meeting. It's a great honor to be here. This is where I come from in London. At the moment, actually, there's no snow, but it's quite cold, and so it's a great treat to be here in Pune. And I've already discovered the Trump Towers, which are opposite of the Aga Khan Palace. Coming to organ protection, it's a broad theme, and I'm going to focus on particular aspects of organ protection during cardiopulmonary bypass, on perioperative organ damage and clinical relevance, strategies towards organ protection in the myocardium, brain, and the kidneys. And with regards to myocardial protection, I'll talk about different strategies. I'll talk about perioperative cerebral monitoring and cerebral protection, and very briefly at the end about renal protection and renal markers. In the UK, we perform about 35,000 cardiac cases every year, with the number slowly decreasing, but the risk factors, they are slowly going up. Here, for example, the age is increasing regularly this is over the last 10 years, from 65 to 67%. And with these increasing risk factors, the Euroscore has been increasing over the last 10 years from 6% to 7.5%. Interestingly, though, the adverse outcomes after cardiac surgery and in-hospital mortality has been reduced from 3.5% to almost 2.5%. So despite the increased risk factors, mortality, in-hospital mortality is slowly going down. You might be aware of a recent study which was published in Anesthesia in 2015, where 110,000 procedures were analyzed over a period of 10 years. And this graph shows the estimated probability of in-hospital death within 3 months of surgery for patients with an average Euroscore risk. And every line here on this graph represents one anesthetist, and 190 consultant anesthetists have been assessed. And this graph is adjusted towards each hospital, and this graph is adjusted to the hospital and to the surgeon. Sorry. And you see there is a very, very low variability in relation to each anesthetist. In contrast, the surgeons have been assessed as well, and there's a much larger variation with each single surgeon and the estimated probability of in-hospital death. However, overwhelmingly, the patient risk accounted to 95 or 96% of the variation in hospital mortality. Surgeons accounted for 4% only, and anesthetists to 0.25%. So this basically means that with regards to in-hospital mortality, the anesthetist did not appear to affect in-hospital mortality. And in this editorial by Peter Alston, this was discussed, and he rightly writes that if there's little or no relationship between anesthesia and mortality, then mortality, in-hospital mortality, may not be the most suitable measure of performance and training for cardiac anesthetists. There are other important patient outcomes from cardiac surgery that the anesthetist may influence. Indeed, some such as stroke may be considered worse than dying for some patients. And this brings us to post-operative organ injuries in cardiac surgery, and the adverse outcomes have a high incidence. In the UK, we saw these adverse outcomes in the ERICA trial, and the incidence of post-operative mortality at 1 year was between 4 and 6%. The incidence of myocardial infarction was around 21%. This was in patients with a Euroscore of 5 and above. The incidence of acute kidney injury was about 38%, and this was including mild kidney injury as well. in this landmark paper, delirium, the incidence of post-operative delirium in cardiac surgery was about 46%. So we have high incidences of these post-operative morbidities, which then have effects on post-operative mortality beyond in-hospital mortality at 1 year, 3 years, and 5 years, which is also of importance. Starting with post-operative myocardial injury, how do we assess it? And this is just one of the trials showing a very, very strong relationship between post-operative troponin and post-operative morbidity and mortality. And what is important to understand is that troponin is an intracellular marker, so even with a minor release into the blood, into the serum, there is already injury taking place. And so we see this in this graph. Even small amounts of increase of troponins indicate myocardial ischemia and potentially worsen post-operative outcome. What can we do to protect myocardial, the myocardium? I have to start with the basics. First of all, our daily bread and butter. Apologies for them. For coming up with this first, but it's really important to maintain myocardial oxygen delivery, and this includes to respect the oxygen content of the blood and also the oxygen delivery, which includes the cardiac output. Marco Ranucci has come up with this really nice graph which brings together the oxygen delivery, which needs to be maintained at a relatively high level in order to secure oxygen consumption, oxygen uptake. And it is assessed can be assessed by mixed venous oxygen saturation, which goes down if oxygen delivery decreases, and by lactate, which comes up. And there is a threshold, and if we go beyond the oxygen delivery threshold, then there will be myocardial ischemia. How about perioperative hemodynamics? And there have been recent papers discussing hypotension and tachycardia and with regards to post-operative injury. In this observational multi-center trial, 890 patients were assessed, and they were 60 years and older and had underwent vascular surgery, and post-operative troponin was measured. And interestingly, in this vascular cohort, intraoperative hypotension, defined as 40% decrease from pre-induction for longer than 30 minutes, was associated with increased risk of post-operative myocardial injury. So the associated editorial asks rightly, is 80, the mean arterial pressure of 80, the new 60? How about preoperative tachycardia? This was assessed recently from a group in London and North America. This was part of the vision study where almost 16,000 patients were assessed, and 10% of these patients had increased heart rates with more than 96 beats per minute. And interestingly, these increased heart rates were independently associated with post-operative myocardial ischemia, with myocardial infarction, and with mortality. What can we do what else can we do to protect the myocardium? Continuation of preoperative medications. This is a class 1 indications from the European and North American guidelines. So we do continue beta blockers and statins, as was discussed in this really nice review, which was published last year in Anesthesia. How about ACE inhibitors? There has been a study from last year which looked retrospectively, this is again a sub-analysis from the VISION study, in relationship with withholding ACE inhibitors or AT2 receptor blockers and post-operative outcome. And there was the results of this study showed in 15,000 patients that withholding ACE inhibitors and AT2 receptor blockers before non-cardiac surgery was associated with a lower risk of death and post-operative vascular events. how about starting new cardioprotective medication? I'll keep this very brief because you are probably all aware of the POISE trials. And in summary, on the one hand, they did show that metoprolol does reduce a composite outcome of cardiovascular death, non-fatal myocardial infarction and non-fatal cardiac arrest. However, there was an increased death with metoprolol started on the day of surgery and stroke. Similarly, in a different POISE trial with aspirin, that was associated with major bleeding, and clonidine was associated with hypotension and an increased risk of non-fatal cardiac arrests. There are only Class B recommendations with the North American guidelines to start beta blockers, however, several days before non-cardiac surgery, and Class 2B recommendation with the European and North American guidelines to start rather atenolol or bisoprolol instead of metoprolol. Briefly about propofol and volatile anesthetics. In order to understand the protective effects of these drugs, one has to understand a little bit about myocardial reperfusion injury, and which has been reviewed over 10 years ago in this nice review. And this is from animal studies. We have the underlying ischemia or myocardial infarction in the hearts, and if then after ischemia, after brief ischemia, this is exposed to reperfusion, then the whole ischemic area will be, or the whole infarcted area might potentially increase, and this is due to the oxygen paradox, calcium paradox, or pH paradox. And I won't go into detail, but one can basically imagine that it's similar to having a small fire, which is representing the ischemia, which is then, if you add oxygen, it's worsened dramatically, potentially. So the idea is that propofol protection or volatile anesthetics can help with the or reduce the ischemia reperfusion injury. And this is a 10-year-old study which is always cited, and it has been showing that continuous infusion of high-dose propofol of 7.2 milligrams per kilogram per hour can significantly reduce the ischemic markers as shown here at different time points. This is a high-dose propofol group, which is the striped column at different time points post-operatively. This is troponin I, troponin T. And a recent study published last year from a Canadian group assessed similar dose of propofol, 7.2 milligrams per kilogram per hour, given perioperatively, and it used a marker which is called isoprostane, which is a biomarker for oxidative stress. And in this study, isoprostane was assessed in the coronary sinus. But interestingly, the post-reperfusion concentrations of isoprostane were lower in the isoflurane group as in comparison to the propofol group. So there was less oxidative stress in the isoflurane group. The group also assessed low cardiac output syndrome in both groups, in the propofol group and in the control group. And overall, in contrast to the marker, oxidative stress marker, the outcome was in favor of propofol, and there was a significantly decreased number of patients with low cardiac output syndrome in the propofol group, which is shown here. And this was particularly significant in patients with diabetes, where it had been shown that volatile anesthetic protection doesn't play a big role. This was only shown in animal data before. However, with the large doses of propofol, one has to be careful because the propofol infusion syndrome has been described, and it has been described in doses. This is in the intensive care setting in doses above 4 milligrams per kilogram per hour, and in the propofol protection cardiac surgical patients, the patients received 7.2 milligrams per kilogram per hour. And here's one case report which was observed in Oxford, where it was suggested that a dose of propofol of 5.2 milligrams per kilogram per hour was associated with a clinical presentation of the propofol infusion syndrome. However, the symptoms are very, very unspecific. However, after propofol was stopped, these symptoms were reversed. Volatile anesthetics and myocardial protection can be has been reviewed, and I was involved in this review, and I would recommend this review for everyone who's more interested in reading it. The conclusions are basically that based on experimental evidence, there are proof of concept studies demonstrating potential cardiac, renal and cerebral protection, but so far there has been no large-scale clinical trial investigating the clinical outcome of the potentially protective effects. However, in the last 2 years this has started, and Giovanni Landoni from Italy is conducting a large-scale international clinical trial looking at the hypothesis is that volatile anesthetic reduce mortality from 3 to 2%, and the aim is to include 10,000 patients worldwide into this study, and it's recruiting very well. How about remote ischemic preconditioning? This was published almost 2 years ago, back-to-back by a European study from Germany and the ERICA study, where I was involved. And the question was whether remote ischemic preconditioning in high-risk patients in the UK, 1,600 patients were assessed, can reduce a composite outcome with the primary endpoint, including non-fatal myocardial infarction, coronary revasculation, cardiovascular death and stroke at 1 year, and the outcome was neutral. There was no difference whatsoever between the two groups, and similarly the German study also didn't show much difference. Cyclosporin has been assessed. It's got an effect on the mitochondrial membrane, which has been shown to protect from ischemia reperfusion injury. This is in PCI patients in cardiology, and there was shown that MRI scan showed a much smaller defect if cyclosporin was used. We assessed this in cardiac patients, and we didn't find a significant difference with post-operative cardiac troponin T in all patients. We assessed 83 patients. However, there was, in the subgroup analysis, we saw a difference in the troponin T in patients having longer periods of cardiopulmonary bypass time, and or more injury, more myocardial injury, in other words. And this is also shown in this graph, where this is the cardiopulmonary bypass time. There were lower troponin levels in the cyclosporin group. This has been confirmed in patients with aortic valve surgery from a group in France, where the cyclosporin group had a lower incidence of troponin rises. So in summary, myocardial protection, class 1 recommendations include to continue beta blockers and statins. Class 2A recommendations include volatile anesthetics, and class 2B recommendations include to avoid prolonged intraoperative hypotension, avoid preoperative tachycardia, discontinue ACE inhibitors, start beta blockers days before surgery, and propofol may also be beneficial in cardiac anesthesia. Remote ischemic preconditioning has not been protective in large clinical outcome studies. Coming to brain injury, and we are all aware that delirium increases adverse outcomes. Patients self-extubate themselves. They have longer hospital stays. There are increased costs and higher 6 months and 1 year mortalities. So delirium is associated with a high incidence of post-operative adverse outcomes. Cognitive impairment has been discussed recently, and it is well recognized. However, early decline is mostly reversible. However, there is also persistent decline, but there might also be improvement, which is possible, especially in cardiac surgery, which is associated with improved symptoms and improved quality of life post-operatively, and that has been discussed very well in this recent review. How about injury? The incidence of cerebral injury and cardiopulmonary bypass, this was assessed in this landmark study. The primary outcome included death, myocardial infarction, stroke, and acute kidney injury, and there was no difference. But the neurological outcome was also assessed. There was no difference between the groups with regards to stroke, no significant difference. And in a subgroup of 2,850 patients, the quality of life and neurocognitive function was assessed, and there was no difference whatsoever apart from at discharge. One subtest, digital substitution test, differed significantly at discharge, but at 30 days and 1 year it was normalized, and the results are seen here. How about cognitive impairment and cardiopulmonary bypass and meta-analysis? This meta-analysis identified 13 randomized controlled trials, 2,400 patients, and again there was no difference if cardiopulmonary bypass was used. Recently, silent new brain lesions have been described, and one might consider these as a more objective assessment of post-operative cerebral injury. And interestingly, you can see them here. This is a new silent brain lesion, or here another new silent brain lesion. And in this review, these have been described with an incidence of 25 to 50% of patients after CABG and valve surgery, irrespective of the type of surgery, irrespective of the type of myocardial protection, whether it's off-pump or off-pump. And these new lesions might be seen as objective markers. They are also irrespective of the incidence of, interestingly, of post-operative cognitive dysfunction. So, coming back to the basics with regards to cerebral protection, again, we have to be aware of cerebral autoregulation, and we are all aware of the different variables in influencing this intracranial pressure and the PaCO2. We know that reduction of temperature is cerebral protective because the cerebral metabolic rate and oxygen consumptions are reduced. And we all know that general anesthetic maintains the cerebral autoregulation. So, and this is a study from, these are results from about 20 years ago. So they show that irrespective of the mean arterial blood pressure, the cerebral blood flow is maintained, and if the pump flow is increased, then there is a slight increase of cerebral blood flow. However, during cardiopulmonary bypass is associated with low systemic flows, with reduced hemoglobin levels, with altered cerebral autoregulation, and also with patient and perioperative factors, hypertension, insulin-dependent diabetes, and cerebrovascular disease. So the lower limit of cerebral autoregulation has been studied intensively in a group in Boston, and it was shown that in 230 patients undergoing CABG or valve surgery, the lower limit of autoregulation had a mean of 66 millimeters of mercury, but it was between 43 and 90 millimeters of mercury, so there was a large variability, and there was no correlation between preoperative mean arterial pressure and lower limit of autoregulation. And in addition to that, in a similar study, 230 patients undergoing the same type of procedure, and the results showed that 20% of patients demonstrated impaired autoregulation during cardiopulmonary bypass, and these patients had a higher incidence of stroke, with 13% versus 3%. So what are the results of high versus normal perfusion pressures and neurological outcomes? There aren't many studies, and I'm going to just introduce two studies from the last 10 years. This one assessed 250 patients, two different levels of mean arterial pressure, and there was no difference in individual neurological outcomes. But however, putting together a combined outcome, there was a difference. And this is another study looking at 412 patients, and there was no difference whatsoever regarding neurologic or cognitive outcomes between the two groups. And this interesting trial is assessing mean arterial pressures between 70 and 80 and between 40 and 50, and they look at MRI scans and new cerebral lesions in the MRI scan post-operatively, and we await the results very soon, I think this spring, and that should be interesting to see whether there's any difference in the silent lesions. Regional cerebral oximetry, I need to rush. In cardiac surgery, and we know that cerebral oxygen desaturation predicts cognitive decline and longer hospital stay. And there have been 2 recent studies assessing regional cerebral oxygenation and the feasibility of reversing desaturations. And I'll go a little bit quicker. This study introduced an algorithm of different types of interventions that were shown, and it was assumed that it is feasible actually to apply this algorithm. It was successfully applied, and ischemic cerebral desaturation was always reversed. Another study from Boston showed intervention and the quite high incidence of interventions, including red cell blood transfusion, which is quite interesting, of 30 or 14%, again demonstrating feasibility and successful. And one might question whether depth of anesthesia monitor, the combination of a depth of anesthesia monitor, which has been shown in non-cardiac surgery to improve cognitive outcome, and I'll go through these, the multimodal cerebral monitoring with depth of anesthesia monitor and cerebral oxygenation. The question is whether this can improve post-operative cognitive dysfunction, and in our institution it was shown in non-cardiac surgery that it can indeed improve it. So in conclusion, cerebral infarctions are commonly ischemic and are secondary to either hypoperfusion emboli or global hypoperfusion. And there are many open questions with regards to mean arterial pressure and cardiopulmonary bypass and reversible causes of cerebral injury. Just one brief slide about post-operative acute renal injury. It is again very highly associated with post-operative outcomes. And, but in order to assess the potential strategies of perioperative renal protection, which are shown here in this review article. One or another strategy is shown here in a trial which is starting now with cyclosporin. One would really need to have an ideal kidney injury marker, because creatinine is not ideal. It's a kidney function marker, it's not an injury marker, and it only rises if 50% of the kidneys are damaged. So new ideal kidney injury markers have been proposed, and these include NGAL, KIM1, and other kidney markers, cystatin C. And this is the last cardiac surgery associated NGAL score, which suggests another very highly sensitive kidney marker at an early stage. And this is my last slide. So in this study, they had the perspective to have an early kidney marker. So in summary, outcomes results in cardiac surgery are heterogeneous. So there's a relatively low incidence of in-hospital mortality, but a high incidence of post-operative myocardial, renal, and cerebral morbidity. Myocardial protection, there are promising results in small proof of concept trials with cyclosporin, inconclusive results with volatile anesthetics. Cerebral protection, optimal mean arterial pressure during cardiopulmonary bypass, more questions here than answers. And what is the role of intraoperative multimodal cerebral monitoring? And renal protection, before we can assess any strategy to assess protection, there's an urgent need for an ischemic renal marker in order to explore treatment options. Thank you very much.